Welcome to this explainer of the RCOG Green-top Guideline 55. I'm really glad you're joining us today because we're diving into materials specifically designed to help MRCOG candidates and practicing clinicians master the clinical, legal, and empathetic care required for late intrauterine fetal death and stillbirth. This is a topic that requires not just sharp clinical acumen, but deep, genuine compassion. So our goal today is to really bridge that gap between the rigorous evidence in the RCOG guideline and the highly sensitive care you'll be delivering on the ward. Okay, let's take a quick look at our clinical pathway for today. We'll be covering definitions and epidemiology, communication and environment, induction of labor regimens, essential postmortem investigations, legalities and mandatory reporting, and finally, care in future pregnancies. Let's get right into it. Starting off with Section 1, Definitions and Epidemiology. First, we need to establish the precise legal and clinical definitions that dictate when this specific guideline actually applies. So, the absolutely crucial point here is that 24 plus 0 weeks threshold. In the UK, stillbirth is legally defined as a baby delivered with no signs of life, known to have died after 24 plus 0 completed weeks of pregnancy. Babies who sadly die before this precise gestational age fall into a completely different category, legally classified as a miscarriage or fetal loss, which operates under a completely different legal and certification framework. For your exams and honestly for your daily practice, 24 plus 0 is the magic number you have to remember. Now, to put this into perspective, late intrauterine fetal death occurs in approximately 1 in 250 babies in the UK. When you compare that to something like sudden infant death syndrome, which is about 1 in 10,000 live births, this is a really sobering statistic. It highlights exactly why mastering this care pathway is absolutely essential for every single maternity clinician. It's not a rare anomaly. It's a clinical reality you are going to face. Looking at the MBRA's UK data, there are some absolutely crucial risk factors you need to know. Mortality rates are over twice as high for fetuses of Black and Black British ethnicity, and babies born to women in the most deprived areas are also twice as likely to be stillborn. Now, make a mental note for your exams. Failure to screen for gestational diabetes is highlighted as a major preventable risk factor. Clinically, you also have to remember the maternal risks. There is a 10% chance of maternal disseminated intravascular coagulation, or DIC, within 4 weeks of fetal death. And that specific statistic strongly influences our counseling on the timing of birth, because we simply can't wait indefinitely without significant risk. Moving right along to Section 2, Communication and Environment. This phase profoundly impacts the psychological recovery of the parents, and for those testing, it's a core component of your OSCEs. These good practice points are highly testable standards. When you're communicating, you must use clear language with absolutely zero euphemisms. Don't say passed away or gone to sleep, and avoid medical jargon entirely. Also, you must always offer a professional interpreter. Literally never rely on family members or friends to translate such devastating news. Furthermore, the guideline strongly stresses that parents should be cared for away from the sounds of crying babies on the labor ward if that's safely possible, and continuity of caregiver, like assigning a specialist bereavement midwife, should be ensured. These aren't just nice-to-haves, right? They are expected baseline standards of care. All right, Section 3, Induction of Labor Regimens. The highly specific, evidence-based dosing required here is a prime target for written MRCOG exams. The primary recommendation here is incredibly clear. Your first-line intervention is always a combination of mifepristone and a prostaglandin. And this isn't just clinical preference. This is supported by grade B evidence from randomized controlled trials, which shows superior effectiveness compared to just using either medication on its own. You definitely want to memorize these regimens for your exams. The mifepristone dose is super straightforward, a standard single 200 milligram dose across the board. But the misoprostol step-down is strictly dictated by gestational age. Between 24 and 24 plus 6 weeks, it's 400 micrograms every 3 hours. From 25 to 27 plus 6 weeks, we step that down to 200 micrograms every 4 hours. And once you cross that 28-week mark, the dose drastically reduces to 25 to 50 micrograms vaginally every 4 hours, or 50 to 100 orally every 2 hours. Why the big change? Because the myometrium actually becomes increasingly sensitive to prostaglandins as gestation advances. While vaginal birth is recommended for the vast majority of bereaved women, you absolutely must have an informed discussion about both the physical and psychological aspects of this choice. But here's where you need to be extremely careful, especially in OSCEs. Women with previous caesareans. The guideline explicitly states that the safety of induction with more than 2 lower segment scars, or an atypical scar, is unknown. Plus, there's just insufficient evidence to recommend any specific regimen of misoprostol for use at more than 28 weeks in women with a previous caesarean birth. This is exactly where consultant-level shared decision-making comes into play. Next up, Section 4, Essential Postmortem Investigations. Following the birth, our clinical duty shifts to investigation, helping answer the parent's most pressing and heartbreaking question, why did this happen? Now, this is a vital number to share in your counseling. You must advise parents that with full investigation, meaning postmortem, placental histology, and genetic testing, a possible or probable cause of death can be found in up to 3/4 or 75% of late intrauterine fetal deaths. Knowing this high percentage often really helps parents make the incredibly difficult decision to consent to these investigations. When you're offering those 3 mandatory tests to identify the cause of death, keep this diagnostic yield in mind. Placental pathology actually has the highest diagnostic yield by far, finding a cause in almost 65% of cases. Fetal postmortem follows at around 42%, and genetic testing at about 12%. This diagnostic breakdown is so important because it shows exactly why, even if parents decline a full fetal postmortem, you should strongly advocate for at least examining the placenta. It quite literally holds the key to the diagnosis in the majority of cases. All right, Section 5, Legalities and Mandatory Reporting. These are absolute, non-negotiable standards for both your clinical practice in the UK and your MRCOG exams. Let's walk through the legal certification workflow. First, the stillbirth has to be medically certified by a fully registered doctor or midwife who is either present at the birth or examined the baby afterward. Now pay attention to step 2. HM coroner must be contacted immediately if there's any doubt about the status of the birth. For example, if the baby was born after 24 weeks, but you suspect it may have died before that 24-week threshold, the coroner has to be involved. Also, keep in mind that a baby can legally be registered as indeterminate sex while you're awaiting genetic tests, and parents can legally delegate responsibility for the child's body to hospital services if they choose to do so. Auditing is a massive part of modern obstetrics, right? In an exam setting, you want to ensure you can list these specific databases. All stillbirths must be reported to MBRAC UK, the National Maternity and Perinatal Audit, and crucially, the PMRT, or Perinatal Mortality Review Tool database. Doing a multidisciplinary review of all stillbirths using the PMRT is a mandatory good practice point. Also, if it was an intrapartum death, the Maternity and Newborn Safety Investigations, or MNSI, must be involved. And finally, always ensure that consent for a postmortem is documented using the nationally recommended form, not just some generic hospital consent sheet. Finally, we arrive at Section 6, Care in Future Pregnancies. Because our clinical duty of care definitely doesn't stop at the hospital discharge doors. Looking at postnatal and future care before they're even discharged, it's good practice to discuss contraception and arrange for GP follow-up. Later on, during the postnatal follow-up, you must review the PMRT results with the parents and discuss any identified causes of death. Looking ahead to a future pregnancy, obstetrician-led antenatal care is heavily recommended. And this is key. Parents with a previous unexplained late IUFD must be offered continuity of care with a known, consistent healthcare professional in their next pregnancy. This goes such a long way to help manage the immense anxiety they'll naturally face. As we wrap up this explainer, I really want to leave you with a final thought. You now have the exact misoprostol dosages, the strict legal definitions, and all those PMRT reporting requirements memorized for your MRCOG exams. But as you prepare, ask yourself, how are you going to balance this precise, rigid clinical knowledge with the deep human compassion these families deserve on literally the worst day of their lives? Thank you so much for taking the time to learn this material properly. Your future patients are going to be profoundly grateful for both your expertise and your empathy.